Hello.
Hello.
So, welcome to our last SBI summer series. So, today I'm going to be moderating this topic. I'm Elisa Sumpkin, and today we're going to be talking about emerging technologies. So, pretty exciting stuff going on, and we have a great group of people today. So, I'm going to go around and let everyone sort of introduce themselves. But I do have to say, I think, this topic is going to be great for a few reasons. One, it's the last one. Two, it's just a great topic. And three, I get to be a part of a chat with Dr. Sumpkin Sr. So this is it's a pretty exciting thing to be able to do this with my father, and I think we'll have a good time. So with that, we'll kick it off with you. Do I call you Dad, Dr. Sumpkin? It's weird calling you Dr. Sumpkin. I just can't do it. Even in training, it was just weird. So either or, we'll start off with you and just give a little bit of background, what you do, where you work, and all of that.
Yeah, so I was going to give my first disclosure being your dad, so you better do a good job. Exactly what I told you when you started your residency. And the second disclosure is I'm the chair of the department at the University of Pittsburgh, and it's a pretty big department. We're about 200 so radiologists, and so I don't get to do a lot of clinical work anymore, but still, I just work today. I was doing biopsies all day today, and I still enjoy it very much, and I still try and stay on top of things. I trained a long time ago, did my residency in the early 80s in Cleveland, Ohio, and moved to Pittsburgh 1985, did a fellowship in, at the time, it was called imaging, because there certainly wasn't breast imaging, and there wasn't even body imaging. It was CT, ultrasound, and MRI, so it was all modality based. I did that, and I was the head of CT at Presbyterian University Hospital. That's our main teaching hospital. And I was asked about 3 years into it if I would be interested in being the chief of radiology at Magee Women's Hospital. And at the time, I thought, well, this is, first of all, I don't know what I'm doing. I don't know anything about women's imaging, but I was young and naive, and I said, sure. And I went and I came down to the hospital, and at that time, there was very little imaging in a women's hospital. So there was no CT scanner there. MR had just started. Mammography was in its infancy. Ultrasound was being used for obstetrical ultrasound and GYN, but really not in the breast. So I took some of the skills I learned in body imaging and started to develop them in the women's hospital. And over the course of my career, we brought in everything from stereo biopsy to ultrasound biopsy to MRI to, everything, radioactive seeds, everything, over the years were we adopted at the hospital, and it grew from just 3 radiologists to, I think it became about 15, 18, 20, something like that. And that's where I developed my clinical career. And about 9 years ago now, I became the chair of the department, which, much to my daughter's chagrin, happened right when she was starting her residency. And to have her father as the chairman of the department, I proudly told her that one night, I still remember, and she was not happy, which surprised me. I thought, how could she not be happy?
But it actually did surprise him, is the funny part. He's like, why aren't you excited about this?
Yeah. Totally didn't get it, but we worked it out, and I told her she had to work harder than anybody else because of that, and she did, and she became a great radiologist.
And I can say she still does. Good. Oh.
So that's so that's kind of my story, and well, I hope to share a little bit more as we get through the hour.
Yeah, we'll definitely get back into some of those details. So let's go on to the next one. Somehow I have a feeling it's not going to be as long as that one. So let's let's go ahead. Either of you guys.
Go ahead, Linda.
Oh, Linda, I'm Linda Larson. I'm a professor of radiology here at University of Southern California in Los Angeles and chief of breast imaging. I've been here 20 years.
Mine will be even shorter than that. Matt Miller. I am a breast imaging radiologist at Allegheny Health Network in Pittsburgh. I did all of my training in West Virginia at WVU, and I have been at AHN for a little over 3 years now. And I work with female Dr. Sumpkin.
You can't really say little Dr. Sumpkin because we're about the same height. So, but so again, thank you guys. This is such a great opportunity, and this whole series has really been such a joy to be a part of, and I really hope that we get to spark some interesting conversation and help some people out who want to know a little bit more. So we'll dive right into our topics today. Again, emerging technology. So I think breast is such a great place in radiology to talk about this topic, because so much has happened with breast in the last few decades, and we really, as a subspecialty, have been such a model for other subspecialties in developing our work model, our everything, the technology that we use, all of that sort of stuff. So there's a lot of different things that I think have happened in a relatively rapid pace, and will continue to as well. So we're going to focus on sort of, things that are going on today and all of the latest and greatest, and sort of see where all of that's taking us. But I think that in order to kind of understand where we're at now, we need to go backwards a little bit and give a little bit of perspective. So as we can already tell, I think we have a little bit of information from someone who has a good perspective on where we've come from and how we have evolved to where we're at now. So I just want everyone to understand, and actually I talked to my dad about this earlier, like what was life like, it sounds like I'm going to say what was life like in the dinosaur age, but what was life like, in the 90s when you went into work? How was your day-to-day workflow when you were doing breast imaging? It's definitely not the same, and I don't think I completely understood it until we sat down and talked about it. So I think this will be interesting if we can get that perspective. What was a typical day like back a few decades ago?
So it's fun for me to think back on it and just marvel at where we've come from and to. But so the first part to understand is there were no breast imaging fellowships or anything of that nature. So when I went down to Magee Women's in my residency, breast imaging was optional. I didn't do any breast imaging in my residency, and it was at the time when they were evolving from zero mammography into film screen mammography, but there were no other modalities for imaging the breast. And when I went down to Magee, I learned one of the things that the radiologist was required to know how to do was wire localizations, because basically the way it worked was there was some screening. It was just starting, but mainly a woman would feel something. She would come in. We would do a mammogram. We would see something. We'd get referred to the surgeon. They would ask us to put a needle into it. They would go to surgery, take it out, and then find out if it was benign or malignant. And so I learned about breast imaging by doing wire localizations. And I got RAD-PAF on every case I did, because they all went to surgery. And that was sort of the algorithm for the longest time, for years. And then what really changed everything was stereo biopsy. So one of the things that I thought was interesting about breast imaging in particular was the opportunity to try new things, devices, and so forth. And when I saw this stereo thing, which at the time was very kludgy. I mean, we weren't digital, so you had to literally develop the film in between each step. There was no such thing as spring-loaded needles, so we were doing FNAs. But by the same token, what we were doing for the first time was we were diagnosing something in the breast prior to the woman going to the operating room. And so what we did in the very beginning was start to have these conferences with the surgeons and ultimately the oncologists and others. And back in, I think it was 1991, something like that, we had our first multidisciplinary conference. It was the precursor of that because we had to talk about each case that we did a stereo on to see, well, like, what should we do with that? Should we really not go to surgery? Are you kidding me? And so that went for about a year or two until surgeons actually started to believe that we could diagnose things in the breast short of a surgical excision. And when that happened, all of a sudden, it went from the patient being referred to the radiologist by the PCP, and the radiologist sending the report back to the PCP, who in turn referred the patient to the breast surgeon, who then referred it back to the radiologist to do the wire lobe. Now it went from PCP or screening as it developed to the radiologist. We made a diagnosis with stereo and then subsequently with ultrasound and more sophisticated ways of doing the biopsy. And then we packaged it and sent it to the breast surgeon. So it was a complete paradigm shift of literally radiologists, breast imagers becoming, in a way, the PCP for the breast. And so that changed everything. And then, of course, over time, the acquisition devices got better, and we started doing MR and all sorts of different things. But that single thing, when stereo came, and it completely flipped the paradigm. And believe me, the surgeons were not happy about this. And the PCPs weren't happy about it either. They didn't trust us. There was a huge culture change. And I remember having some very tense conversations with one of our breast surgeons that Elisa knows this breast surgeon, very good breast surgeon. But he wanted me to teach him how to do biopsies, stereo biopsies, ultrasound biopsies. And I said, fine, I'll teach you how to do biopsies, do your radiology residency and your. And so it never happened, obviously. But that was kind of a day back in the dinosaur days.
Well, and I think that was before that. At that time, breast imaging wasn't patient-centric. Like right now, we revolve around the patients. Mm-hmm. And with the MQSA in April 1999, the diagnostics were on site. So before that, we'd call a patient back, do the compression views or spot mags, and then she'd come back for the ultrasound. It was like, 3 or 4 visits before you got the biopsy and the diagnosis. But with these changes, with the biopsy devices, as well as the rapport with the surgeons, I think the breast center concept developed. Like, I don't know that many breast centers in the early or the late 90s, but then they started flourishing after, we became part of the team.
That's right. And we couldn't, if you recall, I don't know when you started practicing, Linda, you're probably too young, but
Yeah.
we couldn't do ultrasound automatically.
Yeah.
You had to get approval to do an
Yeah.
ultrasound. That was a big deal when that we became able to
Mhm.
actually do that if we felt that we needed to.
Mhm. Yeah.
That's just beyond me. I think, particularly
Mhm.
I think Matt and I here, when we get, we'll get consults.
Yeah.
And there's a facility that we'll get consults from that still uses plain film, just regular old film that we
Still
got.
blows my mind because I don't think they don't get reimbursed for that.
No. No.
And I'm thinking, I don't know how anyone saw anything on this. It's just insane.
Well, with the big magnifying glasses,
Yeah,
so
that's
much
true.
counts and stuff.
So that's the other thing. We haven't spoken at all about analog images versus digital.
Yeah.
But of course, for the beginning of my career, it was all analog film.
Mhm.
And so when as screening started becoming more and more prevalent, they would load what you guys probably have never even seen. It's called a multi-viewer, where you could load like 100 cases, and you'd load they were loaded at night by technologists or by secretaries, and you'd have the new one and one old one. You can only fit so much.
And big jackets.
And a
thick
big
film
jacket,
jackets.
big fat jackets and reports. And so you had to go through all that stuff, and you would just kind of go through that, and the demographic information you had was very limited. Everything. And there was no CAD, of course, although we can get into that later. That's a whole other can of worms. But digital changed everything.
Yeah.
I mean, and that was massive.
Yeah, it's quite a shift. And it makes my life a lot easier. So, and it makes you definitely view things differently, I think, kind of knowing where all of this comes from.
Yeah, I mean, we complain nowadays about, getting stuff from outside facilities and, having everything loaded up and whatnot. I mean, the just the art of being able to read a mammogram on a computer is something that, it's an afterthought now. It's something we take for granted when, just thinking back, taking a step back and realizing that, each time that we've made progress in breast imaging, as far as, going to stereo, going to digital, being able to get ultrasounds and whatnot, each one was kind of a watershed moment in that it improved patient care, it improved patients' ability, like you said, Linda, making it patient-centered, and it improved our abilities to be effective as breast imagers.
And
It's crazy to think about.
Just imagine if you lost that piece of film.
Yeah.
It's gone.
Yep.
There's only one of them. And if a woman came from another place, you had to get the film in the mail. And that took forever. The pace is so much faster now.
Crazy.
Yeah, we can see so many more patients now, which obviously has changed everything in itself. So why don't we start sort of focusing kind of on where we've moved, at least now to this moment, and sort of split things up into a few different categories. So I think that, we'll start out with kind of how we have standardized things now over the last 5-10 years, and I think we were definitely at the forefront of this as well. So we've definitely seen improvements in data management, and set, I think, a precedent for other subspecialties in this. So we have the National Mammography Database, tumor databases. We're all trying to kind of stay on the same page with each other and align things and make sure our quality of care is the best that it can be across the country. So, I think starting with maybe something, it's kind of crazy out all of a sudden. The weather over here is storming. So that is not my children in the background, luckily. I hope not. I hope someone isn't digging a fall and it's actually thunder. But I think let's start out with just if someone wants to kind of talk about how we've sort of standardized things, like basically using an NMD, now, and even or even starting out with how we've standardized things with BioRads. Obviously, that's been around for a bit, but just kind of starting out with that concept and where we're at with that.
Yeah, I was going to mention BioRads. I love talking. I just had a high school student today sitting with me and talking to them about BioRads and introducing it for the first time to them, and kind of talking about how we're able to use this standardized method of reporting to convey to anyone, primary care people, obstetrics people, gynecologists, anyone, any patients, our level of concern. And I think that the development of BioRads shows how impactful breast imagers have been in the whole field of radiology, because you had, after BioRads, you had lung rads and LiRads for liver and TIRads for thyroid and PIRads for prostate. I mean, imitation is the most sincerest form of flattery, right? And I think BioRads just is in and of itself a picture of how organized breast imagers have been in the development of our craft.
Yeah, so I think it was in 1994, Carl Dorsey and Dan Kopans wrote about BioRads, and it really revolutionized imaging, just the way you're saying, Matt, because there was nothing like it in radiology. So all of a sudden, they created a lexicon and a standardization that has allowed every other thing, like the NMD and all the databases that we use, and it's going to be a segue into artificial intelligence when we get into that. But it was huge. And another part of it, another thing is the MQSA, because screening was the only breast cancer screening was the only screening test that there was. And so the government got into that and wanted to standardize the quality. So there was a law. And having that law and having BioRads, those two things distinguish breast imaging from anything else. And just like you say, it's now still breast imaging is so far ahead of every other subspecialty within radiology. They're just getting into all the different rads. But there is like a 2-decade head start in our field.
Well, just with the reporting, like we use the MagView reporting system. I don't know what you use, but to keep track of all of our true positives and false positives and recall rate, and look at it every year and talk about it. And so I think, breast imaging is really way ahead of the game when it comes to that.
Yeah, there's no other subspecialty that monitors quality the way we do.
Yeah.
Because peer review is a kind of a tricky thing, and it's very subjective in many ways.
Yeah.
But in breast imaging, PPVs, recall rates, those are very, very quantifiable. And it's good. I mean, if you can quantify quality, that's how you get to value-based medicine. We're the only subspecialty really that's doing it, and I think others are beginning to follow.
Yeah, absolutely. I mean, especially with the advent of screening, lung cancer screening, chest CTs. We just started doing that down at WVU when I was a senior resident. And it's like, I didn't learn of what my lung cancer screening callback rate is, or if that data is even being studied yet. But I'm sure someone thought of it, and if it hasn't been, I'm sure it will be in the future. But like you said, breast imaging has such a head start where I know where my qualities as a breast imager need to fall. I need to know what my callback rate is. I know what my cancer detection rate should be. And it's, being able to kind of self self-evaluate and make sure that I'm doing the right stuff and, make adjustments as needed is something that keeps breast imagers on the forefront of being able to provide appropriate care. Definitely.
We did
Yeah, I
a,
mean, we even in our system, I don't know how every system works, but we get our pathology and every breast biopsy that we do ourselves. Not that we've recommended, but we do.
Yeah.
We get the result in Epic, which is a really nice form of feedback, or at least that continuous care that you're going to get at sort of every point to make you sort of understand what's better, or what to make you better at, and just learn more.
Mhm. We also use REDCap a lot. Are you familiar with REDCap?
I've
It's,
heard of REDCap.
It's a web-based tool funded by the NIH. And that lets us put clinical information as well as images in DICOM format. And that works really well for our research projects. And it also, we started doing faculty evaluations in it. We created a worksheet for each faculty member. So from year to year, you can just look at last year's and add or take away. So it's really, a wonderful system, the REDCap.
We created this tool. I actually presented it at SBI a number of years ago, a continuous learning tool. So when you read a screening mammogram, at whatever point it hits pathology, you're notified that a diagnostic was done, that a biopsy was done. And so you get to see all that. And you can ask for things like, I want to know when the MR happens, and you'll get the MR because, in your busy day, you forget all these things.
Yeah.
So it'll keep popping up. So you have continuous feedback on all the ancillary imaging studies and labs. And we started that in breast imaging. And now, since I have some influence over our informatics department, we've generalized that for all the radiologists. Get that. It's great.
Yeah,
That's cool. Now I will say Epic, Epic's probably the most common EMR throughout the country. And, we use Epic, and I'm able to, I created like a template where it will give me, whenever I click this button on Epic, on the MQSA button, it'll give me the list of all the zeros that I gave on screenings. And so I can see how many of them, got BI-RADS 2 or BI-RADS 1 or BI-RADS 4 or 3 or whatnot. And then, I don't go through each one because there's too many of them, right? But the ones that, I'll flag ones that I was interested in seeing, or, if there's a 4, and I'll go in and I'll look at the 4 or the 5 even and say, oh, okay, yeah, absolutely. And I kind of keep up with that. And that's just that. Literally, it took me a half hour to create that in Epic. I taught myself.
Yeah, it's really a helpful tool. Just something else to sort of give you continuous feedback.
Mm-hmm.
Does anyone want to specifically say anything about the NMD and kind of where that's going?
I knew we were going to talk about NMD a little bit, and it just coincidentally, when I came home, I opened up the AJR for this. I still get hard copy. Do you guys get hard copy?
Oh yeah, no, my hard copy's back there.
So
I tried to get them. I don't. I prefer them.
Yeah.
So the lead article is the impact of COVID-19 pandemic on breast imaging and analysis of the NMD.
Mm-hmm.
And so they looked at time periods pre-COVID, during COVID, post-COVID, and they looked at the decrease in screening, diagnostics, biopsies, breast cancer diagnosis in all of these periods of time. And they also looked at subsets of women who were particularly adversely affected by it. And I was thinking, that's amazing. I mean, we could have never done anything like that. They looked at millions and millions of mammograms from like 400 centers or however many participate in NMD. And they knew exactly what percentage had diminished in all of those categories. And it still hasn't come back, by the way.
Right.
no.
It hasn't come back to that level. And so there's a lot of, we're going to be seeing over the next several years, a number of more advanced breast cancers. But it also, like, for example, one of the groups of women that were particularly affected, older women, as you could imagine, an Asian woman. Like, who would have known that? But so it's really, I just thought that was an amazing example of the power of that cumulative database.
Mhm.
Yeah, it's very powerful, and still, I think we're still working on it. I mean, our system, we're kind of just getting into it now and inputting all of the data. It's a little bit of effort to kind of work out all of the kinks, but I think has a lot of potential.
Mhm.
So, anyone else have any comments about that?
Well, plus the thing that you could do that you could never do before is benchmark your performance as a breast center, as an institution, to others around the country.
Mhm.
Like, I mean, that's really important, and I think key.
Mhm.
Yeah, I think that is huge. And where else can we do? I mean, we're not doing that anywhere in other subspecialties. So again, just another way how we're kind of leading the way in
I mean,
breast.
I get nervous when I get my report card.
I know. I do too.
Okay,
Honestly.
Yeah,
You
it's a
know.
little frightening.
Mhm.
Absolutely.
So let's talk a little bit about some of the different modalities that we're kind of using now that have that are a little bit on the newer side. How we're actually, you know what? Let's before we do that, I think I'd like to chat more about the risk assessment, and then kind of we'll lead more into modalities because that's sort of what we're using based off of risk assessment as well, because that's another thing that has been more in the recent years that we've been focusing on, and not everyone's doing it yet in breast, but I think is really catching up. So just let's talk about what any of you use at your own institutions. What are the benefits of doing this? And just your thoughts in general on doing risk assessment on breast patients.
Yeah, we are doing them through the MagView. We're doing the Tyrer-Cuzick.
Mm-hmm.
And, I really wanted to do it. Some of my colleagues didn't really want to do it because they didn't think it was accurate. So the patient fills it out, and then the technologist goes through it and makes sure, she understands all the questions. And I love it. We found for our high-risk women, we recommend the MRI.
Mhm.
They get an MRI, and we found a lot of cancers with that. So one of our sites does not have it yet. And I think it's a huge loss. I mean, we're gonna, eventually, we're hopefully within the next year we'll get it. But I think it's really important for these patients.
Yeah, I agree. I mean, well, everything is this whole concept of risk assessment, which AI is going to help us with, by the way,
Mm-hmm.
to help us get into personalized screening paradigms. It's going to be critically important. And at our institution, we struggle with it. We get all of when we're reading screening mammograms, for instance, we'll see the relatives, we'll see the breast density, obviously, if they've been gene tested and whatever. But it's not like a formulaic presentation of a percentage lifetime risk.
Mm-hmm.
And I think we need to get to that because particularly, and we'll get into abbreviated MR and other forms of high-risk screening and intermediate risk screening.
Mm-hmm.
In the abbreviated MR programs, as they're developing now, we're going to be doing intermediate risk patients, and we have to be able to define those patients. we work really closely with our high-risk clinics. So they get, right now, they'll get referred to the high-risk clinic if they have factors, and then they come back, then the high-risk clinic is ordering the MRs. Or if we can recommend the MR based on what we're seeing, but it's just not it's not formalized enough at our place. And I really do think that's something we have to work to improve.
Mhm.
We got a question. I don't know if you guys saw it
Yeah.
from Joy, who asked if we do density scores with our Tyrer-Cuzick assessments. And I think by definition, you have to.
Mhm.
Yeah, I
It's
believe
included.
it's in there. Yeah.
Yeah.
Yeah, it's definitely. I mean, we know too, denser breast, increased risk. So obviously, that's a good thing to include in there. But we're all kind of leading into this personalized care for patients. It's not one size fits all. One woman's risk is going to be completely different than another,
Mhm.
and the way that we're screening them shouldn't be the same.
Mhm.
And I think our ability to evaluate breast density is really very rudimentary right now,
Mhm.
because it's not just, it's very, unless you have Volpara, one of those algorithms, which even those are, I think, flawed in that it's the texture, it's the pattern. There's a lot more to it than just looking at the amount of whiteness on a mammogram.
Mhm.
And I think that's where the different sorts of AI programs are going to really help us in analyzing the texture of the breast. And then beyond that, we're going to be doing more contrast types of studies, whether it's MR, whether it's CEM. In the background parenchymal enhancement is going to be very important, and that needs to be factored into it as well.
Mhm.
Absolutely.
Yeah.
So real quick plug, since we're kind of touched on density or whatnot, if you're really interested in density, go back and watch last week's episode hosted by our very own Dr. Larson.
Funny.
Matt gets very excited about breast density, as I've
Yeah.
heard.
Yeah.
Can talk about it all day.
It's really important. Like, it's my soft spot too. Really is.
It is. It's a great topic.
Mhm.
So, okay. So, and then with that risk assessment, obviously, we're sort of categorizing women based on, this like low risk, something intermediate, and then we have our high risk patients. And so for a while, at least, what we were doing is, your high risk patients, 20% or higher, they're going to get something more than just your regular screening mammogram. And so, we were telling them they needed to get something else, probably a high risk screening MRI. But now we're taking it a step further, right? And that's where our risk assessment is really helping us in that. So, I think that, with that, we have a lot of other options that are kind of coming out. And that can sort of lead us into the different things that we're doing now. So, for our high risk patients, getting that regular screening MRI is great, but with abbreviated MRI, and I'm not sure, probably most people are familiar with it by now, but using just several sequences in a much shortened time period with the use of contrast to obtain a much quicker scan and still get a lot of information, we can diagnose many, more cancers and than just from a screening mammogram. So with the use of that, and then we've been using screening ultrasound. We have ABUS and contrast enhanced mammography, which I kind of would like anyone to sort of touch on any of those topics, how they're being used, pluses and minuses for any of them, just thoughts in general on those sort of modalities.
Well, we are, the screening ultrasound we offer right now is handheld. and we have our techs do it. And yeah, it takes a while. But we are getting the SoftView Delphinus automated whole breast ultrasound, which is a water bath ultrasound that we initially did the study on. And that is a relatively quick study, and we plan on doing it where, she'll get the mammogram, then the Delphinus, and we'll read them together. But we do contrast mammography. We did it first for research, and now we're starting to do it for diagnostics and hopefully eventually screening. But oh my gosh, it was such a hassle with the power injector, getting the techs to do it, getting the IV started. Even though we're at a breast center with nurses 10 feet from us, we couldn't get anyone to start the IV. Now it's better because we trained one of the mammo techs to start the IVs. So that works out so much better because she loves doing it, so she'll take care of those patients. But initially it was really hard.
So full disclosure, I hate screening ultrasound. I just hate reading them. I just can't.
I know.
And we did a study here with the ABUS. We looked at we published it. It was 1,100 patients. They had DVT and they had ABUS. And we found one additional cancer. And that was only on the second read of the ABUS. By contrast with our CEM experience, and we've been doing CEM for a while now, it's really interesting. When we first started doing TOMO, we were a center that we were part of the original TOMO trials. And GE came to us and they said, we have this CEM thing. We'd like you to look at it. We were all involved in TOMO. I looked at it and I said, this is stupid. Why would you want to do this? It's like poor man's TOMO.
Yeah.
So I was wrong once again. I've been wrong many times in my career, but I was really wrong.
I need to capture this moment. I'm so glad it's being recorded.
So I'm not wrong with anything in parenting, once the buzz of TOMO kind of quieted down and we started really investigating CEM, I was blown away by it. And, we worked out the logistics with the tech starting the IVs and all that stuff. And we're running, actually here at our center, Wendy Berg is running 2 trials now. One is called the TOSUM trial, where we're looking at women with prior history of breast cancer. So how we hate reading women with personal you're looking at scars and this and that. And with CEM, it's beautiful. I mean, this just perfect. Just no enhancement or enhancement. It makes it so easy to read. They're fast. There aren't as many false positives as MR. I mean, it's a beautiful thing. And we're also doing she's doing another trial looking at CEM as an alternate method for screening high risk, comparing to MR. And I think that CEM is going to be huge. I think it's going to change the way we screen, particularly intermediate and high risk. And it's so accessible. It's a mammogram. It's in every department. Now, we're all going to have to deal with contrast reactions. And my daughter is an expert in contrast reactions. And that will be a downside, but there's no gadolinium in the brain.
Yeah.
And and it's cheaper and it's faster.
Yeah.
It's in the breast center. So I'm really excited about it.
Yeah. Because we did a study with our cancer patients for the extent of disease, and it was comparable to MR.
Absolutely.
And all of our county patients, don't have access to the MR as much as the private side does. So it's just magnificent for them.
Yeah.
Are you guys able to biopsy off of CEM?
Yeah, I just did one today.
It's awesome.
So it's, the cool thing about it, it's actually better than MR biopsy.
Oh, I bet.
First of all, it's a lot faster. It's the same time as a stereo. And when you biopsy it, you get the contrast in the lesion when you do your post-specimen radiograph.
Ah,
Hmm.
So you can't do that with an MR
Wow.
yeah. That's
Is
awesome.
it a GE scanner or is it a hologic?
logic.
Hologic, yeah.
Yeah, because wasn't that holding on? I was talking to actually one of the techs over there who was telling me that who was helping out you guys out in all of the studies, and she said it was the breast was holding on to the contrast much longer than you guys originally thought it was going to. Thought maybe it would wash out in 15-20 minutes, but it was hanging in there for quite some time.
Yeah, so the case that I did today was one of those kind of Ditzely cases.
Mhm.
And I told the patient right up front, I said, I don't know if we're going to be able to reproduce this and see it again. Just the same way I do an MR when I think it's
Yeah.
going to be one of those. And sure enough, we didn't see it. But I was talking to Rita Zulli, who's at our place, and she says what she's doing on those cases is waiting like 10 minutes
Mm.
and looking for persistent enhancement, which I waited about 5 or 6 minutes. I probably should have waited longer. But you have the advantage to do that because you literally have like 20 or 30 minutes to play around with, which is pretty good.
Yeah.
Wait, so is that actual technique? So you're doing it? Is it still in a trial phase, or it's all FDA approved now, or what's going on with that?
So all of the cases that we're doing CEM biopsy are coming to us from our trials, but I think it's FDA approved. I mean, CEM is FDA approved.
Yeah.
And stereo is FDA approved. So, and the devices are FDA approved.
Put them together and approve it. Yeah.
Is the patient prone or is the patient
So
up?
we're doing them in our upright hologic. The only thing you can't do, you have to do it in the old stereo way. You have to, like, when I do an upright, I use
Come on.
for the Z.
Yeah.
You have to just do an
Different pairs.
and the pair, and then you calculate the Z off the pair.
Yeah.
But I mean, it's fine.
Yeah.
It's easy.
Yeah. Good.
Now that technique you mentioned about kind of waiting, 5 to 10 minutes and seeing the persistent. I mean, isn't that kind of a sign of benignity? I mean, obviously it's not 100%, but the fact that, you can't really see it initially, but then you're waiting and it's still kind of there and enhancing. I mean, to me, that means good things, right?
Mm-hmm.
Yeah, exactly. Now, here's something else that I discovered today.
Mhm.
So in this case, I wanted, since I didn't do the biopsy, actually, I wanted to order a 6-month CEM, but we're not allowed to do that. It's not part of the
trial.
IRB trial.
Yeah.
So I had to order a 6-month MR,
Oh.
which that'll change, but it's still a little rough around the edges.
Yeah.
So maybe I don't know, just compare a 1-to-1, maybe get an MR now and then do it. I don't know.
How do you know?
Yeah, that'd be a lot.
The two different modalities.
I know.
So that kind of leads it. So that sort of connects me. If you guys did just see that question pop up saying, if the contrast is in the specimen, if you're still seeing it and it's not washing out, you would think washout, as we're seeing, in our MRs, is a sign of something worse. Do you think that corresponds? The fact that you're seeing that it's still there, if it's persistent, is that a good sign?
Well, it hangs around for a good 20 or 30 minutes. We looked at this and we actually published this or presented an abstract. I think about 70% of the specimens held on to the contrast.
Yeah.
We view it radiographically. They don't all. And it was a surprise. We had no idea that would happen, but it's a really pleasant surprise. But I don't think you can say, because I see contrast in the specimen, therefore
Sure.
it's, it's benign because it lasted.
Right.
Because if you think about it, you're really doing the biopsy usually within the first 10 minutes of the procedure. So
Yeah. I don't think we used washout as a criteria for benign.
So when we look at them in all of our trials, we always do the CC first.
Mm-hmm.
So we always just visually look at the CC and the MLO. And if the MLO is brighter than the CC subjectively, we call that persistent, or if they're the same, we call it plateau, or if it's less, we call it washout.
Mm-hmm.
But it's pretty subjective. I think the companies will develop some nice kind of caddish algorithms to help us with that. And they'll probably end up coloring it.
Yeah.
Interesting.
Yeah, so we're kind of just touching on this topic. I mean, we don't have it yet, as a lot of places don't. But it's definitely gonna spread rapidly, I'm sure.
Yeah, the other thing that you can do with it that I think is going to be a huge utilization is the ability to triage between like BI-RADS category 3 and 4As.
Yep.
Mm-hmm.
Like we were looking at that, and you can safely exclude at least 20 or 30% of those kind of on the fence cases.
Mm-hmm.
That's awesome.
That's massive when you
Absolutely.
think about the false positives and the number of unnecessary biopsies we do. So I think it's going to be another great opportunity for us.
We're starting a research project with contrast mammography and radiomics to differentiate benign from malignant lesions. And we're looking at the background enhancement as well too. Because with, that changes a lot when with high enhancement, background enhancement, we can't really see the lesions as well. So that's what we're working on now, hopefully to reduce our false positives.
Mm-hmm.
So.
Right, which is always the goal. That's what we're all trying to get to.
Yeah.
That's very exciting stuff. I mean, this is why I did breast, part of it, at least, it's just changing so quickly.
Mm-hmm.
So it makes it the best subspecialty. Obviously, we're biased, but there's always going to be different ways for us to improve in breast imaging, which is really cool.
Yeah.
Good.
Yeah, it's always something else, and we're always looking for the newest, greatest thing. So, I think we could talk about these kinds of things forever because there's just so much about it. But let's move a little bit on to, for the last few minutes of our discussion here, I want to focus some more on artificial intelligence and where we're at with that. And just all of your opinions on something to do with artificial intelligence, what you guys are using, and where you think that's going. We've touched a little bit on it so far, but let's elaborate on it a little bit.
Well, plug for MAMA real quick. I mean, we're one of the first adopters of AI in radiology and CAD. I mean, CAD is, at this point, it's becoming kind of rudimentary AI, but at the same time, it's still a version of AI, right? I mean, it's something that mammographers had before, anybody else did. And so, I actually have some medical students from Drexel wanting to do a research project, just looking at the state of CAD as, AI becomes this kind of big taboo thing to talk about. And, they just want to see, okay, well, CAD has been here for a while. How's it still doing? And my hypothesis is going to be that bad.
Yeah. I mean, we wrote a paper on CAD, like, I think it was 15 or more years ago when they first started reimbursing it for it, and everybody started using it because we were getting paid for it. And we looked at like thousands and thousands of cases, I think 60,000 cases or something before CAD and after CAD. There was absolutely no difference in our detection. So I think we can all agree that the older versions of CAD are not very good.
Yeah.
Right.
And we're in the infancy of the newer ones.
Mm-hmm.
But I do think that it's going to help us in many different ways. First of all, it'll help us find subtle cancers, which is what the old CAD was meant to do, so perception things. But then it will be much better at just helping us distinguish benign from malignant,
Yeah.
which some of the CADX programs now are getting better at that. But
Mhm.
that's going to be one of them. And I think that CAD is going to also help us with our risk analysis.
Mhm.
So it could look at all of the demographic factors and density factors and everything that's out there and help us come up with this magic number that we're trying to figure out, which could then triage us into like what screening test should we be doing? How often should we be screening? When should we start? When should we stop? All those things. So I think the risk assessment part is going to be really important, and also just classifying and staging cancers. AI is going to help us with, and segmenting them for the extent, and those things. And ultimately, I think from some of the imaging data that AI helps us with radiomics and so forth will help us to describe therapies
Yeah.
like what chemotherapy is going to work, or maybe you don't need chemotherapy. And then AI to monitor the chemotherapy, like how, because to our eye, it's very hard to tell changes a lot of times.
Yeah. 6 months out, 6 to 9 months, we can't really tell.
Yeah.
Linda, what version of CAD are you guys using out there?
We're not using a CAD right now. For the
Okay.
mammography, no, we don't use
Yeah, because I've seen obviously too, they have the upgraded versions that incorporate the three-dimensional, I guess the tomosynthesis
Yeah.
slices in it, which seem fantastic. They
Mhm.
seem like they're really helping.
Yeah.
I haven't personally used them, but they do seem amazing, where they are localizing a lesion, giving you a percentage of how high or low the it thinks that this could actually be a malignancy, and then two, categorizing your work list
Mhm.
based on
Mhm.
most probable cases of breast cancer down to the least probable
Right.
ones. I mean, what a way to improve
Yeah.
workflow.
And there have been some nice papers on the ability to completely triage out the ones that are going to be benign, like
Right.
99% of the time. So it's going to diminish the workload.
Yeah.
Um,
That's where it's
Yeah.
going to shine. We used the old CAD 15 or however many years ago. And
Right.
it was never as good as the breast imaging experts, but it was better than the radiologists, the general radiologists, occasionally reading mammography. So it helped. But yeah.
Yeah, the 2D, the one that just is superimposed on 2D images is just
It's not good.
not great.
Now, I have a question for the personalized medicine. Is the referring doctor going to talk to the patient about their screening regimen, or will the radiologist?
that's a great question, and it kind of leads Elisa into, I think, the last question you were going to ask is like what.
Wait a minute. Who's moderating this?
All right, now ask the question.
Wait, I gotta cut this off here. So I'd like to ask to end this off. I knew somehow this was.
Ask your dad what he thinks about that.
I know. He's trying to flip the switch over here. So I'd like to see the thoughts on where everybody thinks, what if you had to guess, what do you think a day is going to be like in 20 years from now as a breast radiologist? And I guess we can go back to you, Jules Senior, and then go into where you think and how that actually is going to play out.
Well, first of all, 20 years from now, if I'm alive, I'll probably be on a beach someplace, hopefully, and not doing any of this. But
Don't worry, I'll let you know.
But I think I really believe that AI and a lot of the different acquisition devices and all that, but AI in particular is going to make the life of a radiologist it's much better. It's going to eliminate a lot of the stuff that we do that we don't like. And I think we are going to be the consultant, Linda, to answer your question. I think we are going to be integrally involved in defining the personalized screening for women. And I think that the way it's going to be is insurance companies are going to pay a woman for breast care. And it's going to be, the onus is going to be on us to devise the best ways to take care of women. We'll get paid it'll probably be a capitated fee. And we have to do, we better do the right things. It's not going to be this, churning it and stuff, because the health system won't be able to afford it. So I think we will be the captain of that ship. I think we are going to be, as much as we consult now, I think it's going to be even more, both with our patients and referring doctors. I think we're going to be much more embedded, even more so than we are now, in the care of patients. And I think it's all better stuff. And frankly, we may even be treating breast cancers. I think there's going to be a lot. I'd be a lot more worried if I was a breast surgeon than a radiologist.
Oh, yeah.
Yeah, like cryoablation, all this kind of
cryo.
stuff that
I'm
we're
so excited
gonna
about
go to.
cryo.
Yeah. Yeah.
Yep.
Yeah. So I mean, that's a whole other topic. There's so many different possibilities. I think so much has changed already, and we're just going to keep seeing it go at this rate. It's very exciting, and I'm really excited to be a part of it. So
I'm hoping a hologram by the time I retire. I just go, "Whoop, here's your cancer."
Exactly.
Well, the last one that we haven't even touched on is theranostics.
Yeah.
Because they're in molecular imaging is going to change it.
Yeah, I mean, it's huge. There's such a large variety, but we all know my dad can talk for forever, so I'm going to be forced to cut him off here. And I want to thank all of you guys and everyone out there listening. Thank you so much for participating, taking the time to have this conversation. I thoroughly enjoyed it for many reasons. But again, thank you so much, everyone.
Thank you.
It was a pleasure. Thank you guys. And thank you everyone for watching and participating in this. We'll see you all next summer.
Yeah. Great. Bye guys. Thank you.
Thanks,
you, guys.
Lisa.